Tonight I thought we'd come to the House floor and talk a little bit about health care because, for better or for worse, this Congress is likely to be remembered for some time as the Congress that did tackle health care. And the question that's on everyone's mind is, will we help or will we make things worse? Now, 2 weeks ago, Congress was sworn in for the 111th Congress. We took to the floor of the House and we passed, under what is called suspension of the rules, we passed an expansion of the state children's health insurance program. Now, passing under suspension of the rules is a special case. Usually that's reserved for non-controversial items, but anyone who followed the activities of the 110th Congress knows that this bill was far from non-controversial. In fact, it had several provisions that created a good deal of controversy in the fall of 2007 and on into the spring of 2008. But we passed the bill under suspension of the rules because the Democratic leadership told us we didn't need to debate the bill anymore because we'd worked on it the Congress before. But a lot of things were different in this bill, things we hadn't talked about in previous Congresses. And in fact, there are 54 new members of Congress. That means that greater than 12% of the Congress is new this year. That means that between 30 and 40 million Americans did not have representation in Congress when that bill was discussed in the 110th Congress, and their representatives were effectively cut out of the process. Well, when it comes to constructing a health care plan for America's children, I think it's important for us to do it right. Remember that the state children's health insurance program was started in 1997 by then a Republican Congress. It was authorized for 10 years. Everyone who was sworn in the last Congress knew that prior to September 30th of 2007, we would have to reauthorize the bill. What did we do? We waited till the last minute, had a big fight, had to extend it. The president vetoed it, came back. The veto was sustained, fought some more, sent it back down to the president. He vetoed it, sent it back. The veto was again sustained. And then we reauthorized the continuation of state children's health insurance program for 18 months, bringing us to the end of March of this year. So, to their credit, the majority leadership, the Democratic leadership in the House did not wait till the last minute as they did 2 years ago, but they tackled it the first week of the session, but again, tackled it in an odd way. We didn't have a single hearing. We didn't have what's called a markup in either subcommittee or full committee on the Committee of Energy and Commerce or the Committee on Ways and Means. A markup is where you go through a draft of the bill and see if there is any improvements that either side can make. We went through a 12-and-a-half-hour markup last Thursday night on this so-called stimulus bill. I'm not sure we got a great amount of work done in that 12-and-a-half hours, but nevertheless, the minority and the majority, members on the committee who sit way down in the front, who lack seniority, were able to have their voices heard as this legislation through the committee, but not so with the state children's health insurance program. So I guess the question I would have, and this is my fourth term, perhaps I should be getting used to such things at this point, but I still find them odd. If the members on the Democratic side are so confident in their ability to legislate and so confident on the merits of their legislation, why seek to stifle the opposition? What are you afraid of? Bring the bill to committee. Let's have a hearing or two. Let's have a markup. Let's bring it to the Rules Committee. Let's bring it to the floor like we do with bills all the time. What is the reason to hide behind a suspension of the rules on this very, very important legislation? And again, I would stress, 54 members of Congress here in the 111th Congress were not present in the last Congress. So it's all well and good to say, oh, it's old stuff, we've debated it before, we've worked it out before, it's just a rehash of something that's gone on previously. Even if that were true, and it's not, but even if it were true, Mr. Speaker, those 54 new members didn't have an opportunity to weigh in one way or the other. And they may have had some good ideas. That's why we have elections every 2 years. That's why there's turnover in this Congress, because new Americans sign up to offer themselves for service in their country. They go through the rigors of an election. They are elected. They come to this Congress. They're full of good ideas. Why turn them out? Why say, no, what you're bringing to this Congress is unimportant because we talked about it last year. We talked about it the year before. You couldn't possibly have anything to add to this near-perfect bill that was vetoed twice by the previous president. Well, lack of input into the bill has led to a number of problems in the current bill. The bill was passed by the House. It has gone over to the Senate. The Senate is taking it under consideration. At some point, we will likely get it back, whether it's an identical bill to what we sent over there or whether it will have to come back to a conference committee remains to be seen. But nevertheless, the bill has gone from the House over to the Senate and awaits its fate over in the Senate. One of the things that was most disappointing about this legislation, it did not. Remember that this is the state children's health insurance program to enroll children of families who earn at or below 200% of the federal poverty level. In round numbers, that's about families of four who earn around $41,000 to $42,000 a year. So those are the families, the children of those families are the ones that would be eligible for coverage. But there are a number of children in those families that are eligible for coverage that are not covered, about 800,000. And wouldn't it be reasonable to take the steps to cover those children first before we expand coverage to children in higher income brackets? Many of us thought so 2 years ago, a year ago. Many of us still feel that way today, but this was a concept that was not allowed to be debated on the floor of the House. Oddly, and I don't know that I've ever seen legislation quite crafted in this way, we picked the ending numbers and then we were going to build the legislation around it. This bill had to cover 10 million children. We heard it several times from the Speaker of the House on the various Sunday shows. She wanted 10 million children covered under this bill, and she wanted to spend $35 billion. And regardless, instead of the policy informing the numbers dictated the policy in this case. The problem is, under their own Congressional Budget Office estimate, the only way to get to 10 million children to be covered on the state children's health insurance program was to displace 2 million children off of private coverage and put them on a state program. Now, you might wonder, well, what's the problem with that? One insurance is just as good as the next. But talk to your pediatrician in practice in your town. Now, I don't mean your academic pediatrician at the medical center at the big medical school in the metropolitan area. I mean your pediatrician on the street corner, your pediatrician who works in your community. Find out if the state children's health insurance program reimburses at the same rate as, oh, I don't know, Mr. Speaker, Cigna, Aetna, United, regardless of the private insurance company. May differ some from community to community, but I know in my home state of Texas, the numbers are vastly different. The state children's health insurance program reimburses at about a 50 cents on the dollar rate compared to private health insurance. That's a significant change for the practicing pediatrician because pediatricians, after all, function very close to the margin. They don't have a lot of excess in their cash flow every month. So the effect of displacing 2 million children and essentially cutting the reimbursement rates for 2 million children is in fact going to be significant, to say nothing of the fact that now the child is on a different insurance than the parent, and that creates some difficulties with just getting care when the time comes to get care. Now, the other thing this bill did, which I'm really questioning whether it was a good idea, it weakened the requirements to verify citizenship. There's a concept known as attestation. There's simply a test for citizenship rather than having to show proof of citizenship, like some type of identification card. So if someone comes into the office where you enroll in this program and simply says, I am a U.S. citizen, that is going to be, under the new Democratic bill, that is going to be proof positive that that person is indeed eligible to join the, to sign up for the insurance. Now, many Americans, tax-paying Americans, and I know Secretary of the Treasury doesn't pay taxes, but many Americans do pay taxes, and it's of concern to them that tax-paying Americans are now going to be paying the freight for people where we're not even sure if they're in this country legally. If that's what we want to do, we at least need to be honest with the American people and tell them that. Say, we're not really even going to check as to whether or not these individuals are citizens as they sign up. And it may be for the best of intentions. We want to be kind to their children. We want to provide them with health insurance. After all, it's cheaper to provide insurance at the front end than high dollar care at the far end, but we need at least to be honest with the American people and tell them that's what we've done. But I don't know that information has actually made it out into middle America. I rather suspect that some people will be upset with that information when they find that out. But the bottom line is, as the bill stands, as it left the House of Representatives, the government will end up covering children that may or may not be United States citizens. Another problem with the bill, as written, is the funding is not provided by any sort of stable funding source. Regardless of how you feel about taxes on cigarettes, or so-called sin taxes, excise taxes, regardless of how you feel about that, what happens as a practical matter when you fund a bill like this with a sin tax, with a tax on tobacco? If you are successful, you drive down smoking rates, which arguably is a good thing. But if you're successful, you reduce the funding available to fund the program, and that would be a bad thing. And this discrepancy is not reconciled within the bill that we passed on the House and sent to the Senate. The other real problem with the stable funding source is this funding source in this bill that we passed out of the floor of the House funds the bill for 4.5 years on a 5-year authorization. So that means after 4.5 years, everybody falls off a cliff because there is no more money. What happens then is anyone's guess. I suspect, as Congress always does, it will find someplace else to gather the money, but that means we do take it from some other source. A twist that actually borders on the bizarre. You wonder what it was even doing in the bill. The State Children's Health Insurance Program bill, as passed the House of Representatives 2 weeks ago, prohibits building physician-owned hospitals or expanding existing physician-owned facilities. Let me just say that again, because it is so incredibly bizarre. The bill prohibits building physician-owned hospitals or expanding existing physician-owned facilities. Now, where else, what other government in the world would prohibit someone from a lawful business practice simply because of the type of professional degree that they have? You go to medical school, and you can't build a hospital. What an odd, bizarre twist, and what an odd thing to put this in a bill for funding state children's health insurance. So, state children's health insurance, a good cause. I supported the original concept of S-CHIP. I supported the reauthorization, the 18-month extension we did in December of 2007. I would have supported a reasonable reauthorization in this Congress. But this was anything but reasonable. It was a badly written bill. It badly needed to be, and again, it just begs the question, are we going to be helpful, or are we going to foul things up in this Congress, particularly when it comes to health care? Now, I already alluded to the so-called stimulus bill that came through the House Energy and Commerce Committee last Thursday. We debated the bill. We marked up the bill for a 12.5-hour session. It wasn't just health care. We had a lot of stuff thrown in that day. We had energy. We had all kinds of things that were heaped into that bill, but we did debate health care. Oddly enough, the health care part of that debate, you heard Mr. Kucinich talk for an hour earlier. He thought that was a pretty important part of the stimulus bill. So oddly, a very important part of the stimulus bill was left right until the very end, and then our time was severely curtailed. We were allowed to talk for 2 minutes instead of the normal 5 on any amendment that we had to this bill. One of the amendments proposed by Mr. Whitfield of Kentucky, you know, we have a problem in Medicare. Every year we come in and we say, we haven't got quite enough money, so we're going to cut doctor reimbursement rates just a little bit this year and a little bit next year, and over time you begin to talk about real money. So we are facing a reduction in physician reimbursement rates in December of 2009, 11 months from now, and that reduction in reimbursement is going to be 20%. Well, what's the practical effect of that? It makes it harder for people to find a doctor who takes Medicare. Mr. Whitfield's district is in Kentucky. This has been a particular problem for him, and he had an insightful amendment to try to correct this problem. Now, you look at the stimulus bill as drawn, we don't have to justify paying for anything in the stimulus bill. It's money that just comes from somewhere. In fact, one of the headlines in one of the magazines up here a few weeks ago was, "It's raining money." Well, if it's raining money, and we perennially have a hard time finding the funds to do away with this physician reimbursement nick that we put in every year, why not just repeal that part of the Medicare law? Why not repeal the so-called sustainable growth rate formula just outright? Since cost is no object, doesn't matter how much money we spend, there is no upper limit. And truth be told, this isn't real money anyway. This is money that's already been spent. It's already been reimbursed to the doctors. But because of a funny budget gimmick in the Medicare law, we've got to go back for well over a decade, well back to the early 90s, every year, and capture all the savings we should have gotten had we enforced this every year and tack that onto the end. So they're not real dollars. They've already been dispensed. In fact, if we were a private company and did this, we'd look just like, well, I won't go into it, but we'd probably have an ankle bracelet if we did this in the real world. But nevertheless, we had an opportunity in amending this bill to repeal the sustainable growth rate formula outright, since we've got money is no object, we've got all kinds of money to spend, and the amendment was defeated. Every Democrat in committee that evening voted against repealing the sustainable growth rate formula. No hesitation. Can I ask you one more question about that? It was simply a straight no to the amendment. Well, suffice it to say, I was pretty disappointed by that. But undaunted, I thought, well, maybe we could offer an amendment. And in fact, this was an amendment offered by Mr. Dingell during the Deficit Reduction Act a few years ago. And this would have stopped the cuts in the sustainable growth rate formula for 2 years. Not a great heavy lift. Again, we got plenty of money in this bill. It seems like money is no object because we can buy grass for the mall. All kinds of things are in this bill. Why not pay for a 2-year moratorium and at least give our physician community a little bit of stability in planning their businesses? Again, turned down. Every Democrat in committee voted against that amendment. Oddly enough, every Democrat had voted for that amendment when their ranking member, Mr. Dingell, when they were in the minority, when that amendment was proposed by Mr. Dingell. Well, we also had some information technology contained within that stimulus bill. Again, you heard Mr. Kucinich talk about it. Information technology is going to deliver untold promise to the practice of medicine. There'll be no problem with money in the future because of the benefit brought by information technology. And in fact, we're going to give our doctors a bonus for implementing information technology. Now, it's not a big bonus, but it's a bonus nevertheless. And this bonus is going to go into effect in 2011. Oh, wait a minute. It's a stimulus bill. It's 2009. So I offered an amendment to accelerate those bonus payments. Let's start paying them in June of this year rather than waiting till 2011. Almost everyone in this body hopes that the recession will be done by 2011, so that bonus will have no positive effect on the recession. Let's go ahead and provide that money to the physicians now. Again, that amendment was defeated. Every Democrat in the committee room voted no. Mr. Barton, the ranking member of the committee, also offered one more chance to allow doctors to own hospitals and surgery centers. Again, that amendment was turned down. Every Democrat voted no on that bill. Now, there are a lot of things we could talk about in health care. I see I've been joined by some of my friends. Just 3 quick things I want to mention when we talk about going forward and what perhaps we'd like to see in any sort of health care legislation that's crafted. There's no question that the way the current tax code is drawn, it does discriminate against individuals who want to own their own insurance. It does load the system to those who earn at the upper end of the income scale. So at some point, someone is going to have to look at that inequity and see if there's not a better way to approach it. But in the meantime, just keeping it very, very simple, why not allow someone who purchases their own health insurance, why not allow that to be deductible from their income tax? If they're working and they want to purchase their own insurance policy, but they don't really make enough money to pay much income tax, provide them a tax credit. Give them a little help. That's the people that Mr. Kucinich was talking about, the working poor. Sure enough, let's give them a little bit of help. And if we wanted to go one step further and help those who are without health insurance, why not provide, call it a voucher, call it a tax credit, a pre-fundable, advanceable tax credit, call it what you will, but why not perhaps incorporate that into the tax code? 3 relatively simple things we could do tomorrow and vastly have a significant effect on the ability of individuals to have health insurance in this country. We're going to hear a lot of discussion over, I suspect, over the next months and even years, the whole issue of, are we going to have to mandate coverage, or do we have some other way to get people the coverage they need without requiring a mandate? Now, some people may recall we face that same dilemma in the Medicare Part D. And in Medicare Part D, many people wanted a mandate. You're going to have to buy this prescription drug coverage on Medicare. Dr. Mark McClellan, who was the head of CMS at the time, Secretary Mike Leavitt over at Health and Human Services, decided they were going to take a different track, and I'm so grateful that they did. They said, we're going to create programs that people actually want rather than forcing them into a program that may be of limited utility for them. So they did. They spent a great deal of time crafting programs that would actually help people. They had 6 protected classes of drugs. There had to be at least 2 options in each protected class of drugs. Now, I've been so far removed I don't remember them off the top of my head. But it was a brilliant strategy, and as a consequence, the sign up for Medicare Part D, the percentage of seniors who now have some type of credible coverage for prescription drugs is in excess of 90%. And more importantly, the satisfaction rate is in excess of 90%. And perhaps most importantly is it didn't cost nearly what the projections said it would cost initially. The initial premiums for Part D were set by the Center for Medicare and Medicaid Services at nearly $39 per member per month. The actual cost has come in somewhere between $22 and $24. It's gone down a little bit in subsequent years, but a significant decrease over what was projected by both Congressional Budget Office, CMS, and even the Office of Management and the Budget down at the White House. So a much more reasonable way to approach things rather than telling people what they must do, and that's always hard in a free society, always hard. My home state of Texas has an individual mandate for automobile insurance. But not everybody signs up for it. In fact, the city of Dallas has just started a program where if you're stopped for whatever, a taillight busted or ran a red light, and you don't have car insurance, your car's towed. See you later. You're on the street. Find another way to get home. Well, we can't really do that in health insurance, but that just underscores the difficulty that you have with enforcing a mandate. But creating programs that people want. Remember, over 90% of seniors now have credible prescription drug coverage because someone took the pains to find out what people wanted, find a way to make it cost effective, and find a way to make it available to them. Sides of the aisle, when we talk about health care in this Congress, do remember it's more about cost and coverage. This is about caring for people. Medicine, I can say this because I spend a lifetime practicing medicine. It is both an art and a science. It's constantly evolving and transforming. We're on perhaps the cusp of one of the most transformational times that has been seen in medicine ever. The human genome has been sequenced. We can know more about people before it happens to them than at any time any group of healers ever had that never had that kind of power in their hands in the past. Dr. Eliza Zerhouni recently left as the director of the National Institute of Health and used to talk about medicine because of the discoveries of the human genome. Medicine is going to become a great deal more personalized. Well, that's a good thing, personalized medicine. We'd all like to see that. Medicine more personalized, it's going to become more predictive. Because it's more predictive, that leads to more prevention. But part of the key there is going to have to be a lot more participatory. You cannot be a passive actor in tomorrow's healthcare environment and expect to get the rewards that it is capable of delivering. But how ironic, as we stand upon this transformational time in medicine, what is the one thing? What is the one thing that could divert it from this path? It's the United States House of Representatives. We're inherently transactional, not transformational. We take from one group, we give to the next, And we have the power within our hands to derail the transformation that is even today taking place in medicine. For all of the faults of American medicine, for all of the faults of private insurers, and Mr. Kucinich detailed them in laborious detail, for all of those faults, things are beginning to move in a positive direction. Information technology, health information technology. Do we really need the government to tell us to write the code for medical information technology? Wouldn't we be better to just simply set some parameters and get out of the way and let the people who know what they're doing actually do that? No, we're going to try to write every jot and tittle of the code so that we control it from start to finish. But the reality is, across the country, and I know this because I've spent the last 6 months going across the country, people are incorporating electronic medical records into their individual physician practices, into their larger hospitals, into their health maintenance organizations, into their insurance regimes. It's happening already. Now, part of the challenge for us is to make certain that all those parts interconnect properly and that there is proper communication, that there's proper transparency, so that the patient who goes to one large multi-specialty clinic in the Midwest and transfers to another large multi-specialty clinic in the gentleman from Ohio's hometown, that those two clinics, the records from those two clinics, can talk to each other. But that's just a technical problem. That can be solved. And it doesn't require the United States Congress writing the computer code in order to make that happen. In fact, if we'd relax a little bit on our regulatory laws, the so-called Stark laws that were written back in 1981, it's the 21st century, for crying out loud. That's nearly 30 years ago, and we're still putting the same constraints on medical practices today that they were back in 1981. If we define privacy once and for all, tell people what we mean by privacy, and then not change our minds every 3 months, maybe they could get this done. But there is a transformational change taking place, and you can see it in insurance companies, you can see it in physician practices, you can see it in hospitals and clinics, federally qualified health centers across the land, and the only thing that can stop this evolution in healthcare is the United States Congress. So that's a kind of a daunting possibility, and when we hear people talk from the floor of this body about all the wonderful and great things that they want to do in healthcare, we do always need to remember that we have it within our power to allow that transformation to blossom or to stop it dead in its tracks. Now, I've been joined by some